All right, let's dive right in. We're going to run through a classic surgical oral board exam. I'll be your examiner. The topic? A true surgical emergency, esophageal perforation. Let's begin.
Candidate, that's the page you just got. The patient is in distress in the ER. Talk me through your immediate actions. What are you going to do, step by step?
Okay, my first priority, before anything else, is to assess and stabilize this patient. I'm thinking ATLS principles here. I need to make sure he's stable before I can even think about definitive management.
So, I'm heading to the bedside and I'm running through the ABCs. First, airway. Is it patent and protected? B for breathing. I'll check his oxygenation, listen to his chest, and get him on supplemental oxygen. And C for circulation. I need to know his hemodynamic status. We're immediately securing 2 large bore IVs, drawing a full set of baseline bloods, and starting fluid resuscitation, likely with Ringer's lactate.
While my team is doing that, I'm taking a very focused history. That story of forceful vomiting is a massive red flag. It's the classic history for Boerhaave syndrome. I'd also specifically ask about any history of long-standing GERD, if he might have swallowed a foreign body or something caustic, or if he's had a recent endoscopy. Of course, getting the rest of his past medical and surgical history is also crucial. My physical exam has to be systematic. I'm looking at him generally. Is he in distress? What are his vitals? But the chest exam is absolutely key here. I'm listening for decreased air entry, which could mean a pleural effusion, and I'm carefully feeling the neck and chest wall for surgical emphysema, that classic subcutaneous crackling. You can't forget the abdominal exam either. I need to rule out any signs of peritonitis.
Okay, so those initial bloods we drew are going to give us some vital clues. I'm fully expecting the CBC to show a high white cell count, or leukocytosis, which points to infection. The arterial blood gas and the lactate level are critical. They'll tell me if he's developing acidosis or is in shock. And of course, we need a coagulation profile and a group and cross-match ready to go, because there's a very high chance this patient will need surgery.
Good. The patient is clearly sick, and your labs are confirming that. Now you need to prove the diagnosis. What's the definitive imaging study you're going to order? Be specific.
My imaging modality of choice, without a doubt, is a CT scan of the chest and abdomen. And it has to be with both IV contrast and a water-soluble oral contrast, like gastrographin. The 2 pathognomonic findings I am looking for are extraluminal air, that's air outside the esophagus where it shouldn't be, and contrast extravasation, which is the oral contrast leaking out of the esophagus into the surrounding tissues.
Let's move on. The diagnosis is confirmed. Now we get to the most important part of this whole scenario, your clinical judgment and your decision-making.
So the scan shows a contained leak. Now, a lot of surgeons would rush straight to the operating room, but is that always the right call? Tell me, under what very specific circumstances could you manage this patient without surgery?
Not operative management is definitely an option, but only if some very, very strict criteria are met. First, the CT must show a contained perforation. Second, the patient has to be hemodynamically stable, so normotensive with a pulse less than 100. They can't have any signs of ongoing sepsis, and we'd want to see only a mild leukocytosis. If any single one of these criteria isn't met, surgery becomes the only safe option.
Very good. So let's assume for this case that the patient does not meet those strict criteria, and you've made the decision to operate. Talk me through your surgical plan.
The surgical approach depends entirely on the location of the injury. For a perforation in the lower esophagus, like in this scenario, the standard approach is a left thoracotomy, usually through the 7th intercostal space. Now, if the injury were in the mid-esophagus, I'd go in from the other side, a right thoracotomy, through the 5th intercostal space.
The key steps of the repair are pretty methodical. First, you have to debride the edges of the perforation back to healthy, viable tissue. Then, I'll do a 2-layer closure. The mucosa with a running absorbable suture, and the outer muscularis with interrupted silk sutures. Now, here's the most critical step of all. You have to buttress the repair. I'd use a vascularized intercostal muscle flap to cover the suture line. This has been shown to dramatically reduce the leak rate. Finally, I'd irrigate the chest cavity copiously and place a large bore chest tube for drainage.
And I have to mention the damage control scenario. If the patient were profoundly unstable, really sick with severe sepsis, a primary repair might be too much for them. In that case, the best option is esophageal exclusion. This is a bigger operation where you create a cervical esophagostomy to divert saliva, staple off the distal esophagus, and place feeding tubes. It's a true life-saving maneuver for the absolute sickest patients.
Good. The operation is over, but your job as the consultant is far from done. Let's talk about the post-operative management.
Okay, so postoperatively, this patient is going straight to the ICU for close monitoring. They'll be kept completely NPO, meaning nothing by mouth, and I would start TPN, or total parenteral nutrition, for nutritional support. The next really crucial test comes around post-op day 5. We'll do a repeat contrast swallow study with gastrographin. If that study shows absolutely no leak, then, and only then, we can start some oral fluids and cautiously advance their diet.
A very thorough answer. To finish up, summarize it all for me. What are the absolute key learning points from this case, and what are the mistakes that simply cannot be made?
Certainly. So, the key takeaways. First, you always buttress your repair. Second, you have to plan ahead with anesthesia for a double-lumen tube to allow for single-lung ventilation during the thoracotomy. And third, a simple NG tube can be your best friend in the OR to help identify the esophagus. But the single most critical factor, the one that determines survival above all else, is time. Any delay in diagnosis and treatment is the biggest threat to this patient's life. A high index of suspicion and quick, decisive action are what saves them. Thank you.